The first little bit is not that important because the first little bit is just my introduction. So my name is Lydia Bartholow, and I'm a psychiatric nurse practitioner over at Old Town Clinic, so just a couple blocks away as part of Central City Concern. And my role there is primarily medication management. So you might be wondering, hey, what are you gonna teach us about difficult conversations about opiates? But the deal is I have these exact same conversations about benzodiazepines. And so I'm well versed in these conversations. And I've also taken some slide sets from two people that I respect immensely, and I've kind of done a mashup of those slide sets. So you're getting some primary care and some medical provider perspectives on talking to patients about opiate tapers as well. So the two people that I've pulled from, the majority of this talk is from two people. Laura Heatsaker is a licensed clinical social worker with Jackson County Connect, and she's just a total powerhouse when it comes to talking about the opiate epidemic. I mean, she just kind of blows my mind every time I see her talk. So I've stolen some things from her with her permission. And then I've also stolen some slides from Brad Anderson, who's an amazing addiction doc over at Kaiser. So some of the slides we'll look at from him are how to actually have those difficult conversations when we're more in the realm of addictions. So my role, again, is to manage medications, but I'm also dually certified in addiction medicine. So I'm going to do some part of the therapeutic piece, which I do as a psychiatric nurse practitioner, but some of this is going to be more in the realm of addictions and out of the realm of mental health. So let's dive in. It looks like more people are back in the room. So what we're talking about today is those difficult conversations that we have when we need to either taper, decrease, or stop opiate medications. I'm sure none of you have this experience in your primary care practice. That was a joke. I got like a couple laughs. Okay. It's something that we all struggle with regularly, right? So what I want to do is I really want to talk about the actual skills that we use in those conversations. How do we have those conversations in ways that feel better for the patients, in ways that feel better for us? And what I want to talk about today is in ways that are trauma-informed. So what we've highlighted here is patient-centered. That means we want to have these conversations in ways that are useful for the patient. We want to have these conversations in ways that are applicable to the patient and feel honoring and respectful. I think oftentimes when we talk about patient-centered care, people get kind of muddled when they start thinking about opiates, right? Because patient-centered care oftentimes translates to us that we do what the patient asks us to do. And yet if the patient is asking us for opiate medications that our medical knowledge says aren't safe for them, we're in this quandary. All right, what does patient-centered care look like if we have to deny what the one thing that the person says they believe really helps them? So we want to do patient-centered care. How do we have these conversations in ways that are really honoring of the patient's lived experience? Then we also want to do care that for us is boundaried and self-protective. And when I say self-protective, I don't mean from a medical legal stance, although I think that's also just as important, but I actually mean from a burnout stance. How do we kind of protect ourselves energetically and emotionally? And I bring this into the conversation because I know from working in a primary care clinic that one of the things that sort of is the heaviest burden on primary care providers, and actually our support staff as well, is having these hard conversations with patients around opiates and other controlled substances. This is one of the things that makes us tired when we go home at night and are trying to hang out with our kiddos. This is one of the things that weighs on us over the weekend. And so when I say self-protection, again, I'm not talking medical legal. I'm saying how do we have these boundaries? How do we self-protect ourselves in these conversations, but also do it in a way that's patient-centered? Because we could walk into the room and just say, nope, find someone else, see you later. That wouldn't be patient-centered. So how do we balance those? And in that context, I want to talk about trauma-informed care, because trauma-informed care as a paradigm already holds those two things. So how many of you guys feel familiar with the concept of trauma-informed care? Okay, so the majority of you. So trauma-informed care is the idea, and let me just differentiate it from trauma-specific care. Trauma-specific interventions are many of the things that Anderson talked about. So it's we know the person has a history of trauma and we do things specifically to address that trauma. Trauma-informed care is a paradigm that says we think and we assume that you may have trauma in your past. We don't know, but we're going to use universal precautions and treat all patients as if they have a history of trauma. And how many of our folks that have chronic pain or are on long-term opiates or other controlled substances have history of trauma? Like pretty much all of them. Oftentimes I have patients tell me, oh, I don't have a history of trauma. 3 years later, something horrific from childhood comes out. I mean, it's just so, it's so consistent, especially in my line of work. And so we use universal precautions. We assume everyone has experienced traumatic things in their life, and we know that's especially true when people are struggling with chronic pain and that central sensitization. Oh, I'm not where I want to be. We also know that opiates feel incredibly good to the traumatized nervous system. The traumatized nervous system functions differently than, say, my nervous system or maybe some other nervous systems in the room, although I don't want to make assumptions about your past. We know that opiates feel incredibly good and are really useful. And I say useful cautiously, but they're really useful when a nervous system is sort of as exaggerated as it is in trauma survivors. Opiates suddenly feel like someone can be safe. So the previous conversation talked a lot about how do we create safety. Opiates feel safe. Suddenly people feel safer when they're taking opiates. And so we want to keep that in mind as we talk to people about taking their opiates away. Because what are you actually saying when you say we're going to stop opiates?
Taking away your safety.
What's that?
Taking away your safety.
Yeah, we're saying taking away your safety. I heard some rumbling in the back of the room. I wanted to make sure I didn't miss anything.
Oh, I just said sin. Oh, wait, that's heroin.
Oh. Gotcha. All right, so trauma-informed care, another tenet of it is it says we don't want to re-traumatize patients. It says that in our medical care, we want to do no harm. If we assume that everyone has a history of trauma, we set up our systems, including our communication systems, to not re-traumatize people. So in doing that skill building and how we have these conversations, we want to make sure that we don't re-traumatize people, that we don't increase their sense of fear in the world or their sense that there's no safe place. As medical providers, that's kind of the opposite of what we want to do. And yet what we know about these conversations is that patients often leave feeling less safe, and conversely, the provider feels less safe. The lovely thing about trauma-informed care is it takes that provider feeling less safe and it honors it just as much as the patient feeling less safe. So trauma-informed care, again, as a paradigm, honors both of those things. It honors the provider and it honors the patient. So before we dive into the skill building, I want to give you guys kind of free rein for a second. Just let it all hang out on what you hate about working with patients that are on chronic opiates or working with patients that are struggling with addiction. What are the things that are burdensome for you? And don't be scared.
The pain never goes away.
The pain never goes away. Okay. So it feels kind of hopeless. There's a hopeless feeling. Okay.
I wouldn't say that I hate it, but the biggest challenge is engaging motivation. So getting them to put forth the effort to do or go with some of the, starting exercise or engaging in services rather than I just want to take a pill, I just want to numb out. This is working. Why are you changing it?
Yeah.
The resistance.
Okay, so the resistance to change. Yep. So far, you guys have been incredibly tame. I gave this same talk on the coast a couple months ago, and people were like raring to go. They were like, I hate this, and I hate that, I hate that. Okay, hand over here.
Just the lack of willingness to engage in other things.
Mm-hmm.
I've tried everything else. This is the only thing that works. I just want to refill.
Yep. So again, kind of this resistance or this kind of I know this thing works for me when your medical mind is saying, well, really the research says that opiates don't do that much for chronic pain. Yep. What else? Outreach and resources. So feeling like you don't have the outreach and resources for people. Is that? Yeah, feeling like you actually don't have the resources to meet people and really get them what they need. Yeah. Okay. One more and then we'll. Yeah, so really understanding these people as being incredibly complex and where does your role fit in and who do you need to refer to? Yep. Okay, one more hand and then we'll.
And that being the only topic of conversation.
Yeah. So feeling like your role in doing preventative healthcare and doing wellness starts to kind of erode in the context of opiates. Yeah, thank you for bringing that up. Okay, so we've still got one more.
When they're on the opiates, it's fine. As soon as you make a change, there's a fear. Are they going to make other patients uncomfortable when they're yelling and screaming? So that fear of them being really labile.
Okay, so the fear of confrontation. Yeah, all right. So I think.
The whole clinic.
Yeah, and so it causes a stir in the whole clinic. Yeah. Okay. And how? All right. Mm-hmm.
because of time, just in compartmentalization by the healthcare system.
Yeah, and so I hear behind that really this, yeah, and sort of this deep isolation on your part. Like, am I really the person? Yeah. Yeah, so some isolation, yeah. And so some things that you guys didn't bring up, you brought up confrontation a little bit, but you guys didn't bring up sort of the emotional burden of that conflict in the room. How many of you guys feel like it's rough to have that conversation? It's rough to feel like you're not meeting people's needs and simultaneously they're pissed at you. Yeah, I hate that. I'm like so conflict averse, right? I did not spend 8 years of my life in school and owe the federal government $250,000 so that I can like fight with people about what I think is the best treatment for them. That was never my goal, and it burns me out. So for fun, let's.
Well, hello, welcome.
We're going to look at one primary care visit. You may recognize the physician.
Okay, lady. I just go by Rachel. We're really laid back here at the Safe Space Clinic. My last name's a total disaster anyway. So,
this is Chloe, by the way. She's my companion pet.
Oh.
Yeah. She goes everywhere with me.
Okay.
Yeah.
I'm not usually super into pit bulls, but that's honor your bringing what keeps you safe here. So anyway, I have a ton of questions I could ask you, but what's most important is what's important to you. So tell me, what brings you into Safe Space Clinic today?
Okay, well,
See how patient she is here?
I have a head injury, so my memory doesn't work very well, so I have a list here.
Oh,
so
okay,
I'm just gonna
okay.
is that okay?
Yeah, yes,
Yeah.
thank you, that is so helpful.
Oh, here.
Oh, yeah, okay. Yes, okay. Oh, wow, okay, so that's a pretty long list there. So we've got about 20 minutes or so.
Well, I mean, there's
a
a lot, and I need for you to get like a full picture of what's happening for me. Otherwise, you're not going to really understand. And so,
okay.
Yeah. So I have it all written down.
I'm sorry. Go ahead.
Go.
Yeah, of course.
So, first of all, I've been in like a lot of car accidents. I've had a lot of
I'm just
broken
logging on
bones.
here.
Okay.
Sorry. Yeah. Okay.
I've got osteoporosis.
Okay. Have you tried?
It's degenerative.
I see. Okay.
Yeah.
Really, I haven't heard of Okay.
My bones are like crumbling. It's so painful.
Okay.
Yeah.
Any bones in particular? Is it your knees, your legs?
Well, I mean, I've got like
discs in your.
I have degenerative discs in my back.
Okay.
I've got really bad neuropathy.
Oh,
if you could see my legs,
yeah.
They're like red and like the veins are sticking out.
Is it like a circulate? Do you get cramping when you walk with them?
No. It's like I have arthritis.
Okay, let me just get your chart here.
I have arthritis in my shoulder. My physical therapist says I need to like not go to physical therapy for it.
Okay, so have you been to physical therapy?
This is just really like.
Okay.
I feel kind of overwhelmed right now, and I'm just like in a lot of pain.
Yeah, no, I see. So tell me, what have you tried that helps for your pain?
In the past, I was on methadone for a while, and that sort of.
Was that at a methadone?
It was at a methadone clinic. I did that for a really long time, and then I was like,
how did you get into the methadone clinic originally?
It was for pain. I went for pain, so it didn't feel appropriate.
Did you ever use any injection?
No, I mean, not really. I needed pain management, and that's what they wanted me to do. So.
Okay.
Anyway.
Usually that's more for. Okay.
Anyway, I left that clinic because I wanted to get off the methadone because I don't abuse drugs, right? So I needed something like legit for my pain. So I went to another clinic, and they gave me OxyContin.
Okay. How much of that were you taking?
I was taking 5 tabs a day.
Okay.
And another, they also.
10s or 20s.
I have it in another list somewhere. I don't remember, but I can give you that at some point.
Okay, that would be really helpful.
Anyway, they also gave me Lortab too, which was also
with the OxyContin on both of those.
Yeah.
Okay, all right. So that sounds like quite a.
And also, I just wanted to also just let you know that I have like last time I was at the ED, they told me I have an abnormal heartbeat.
Oh,
so,
okay. Did you get an EKG there?
Actually, I didn't make it to that, but I did get my last MRI. They looked at my heart and They said it was fine, but it always feels like I'm like having a heart attack.
Okay, on your MRI. Okay.
Or something.
Well,
I
are you
don't know.
having chest pain right now?
Yeah. I mean, I always feel like my heart's racing, and I feel really nervous right now. And this is hard for me to be sharing all this stuff with you. But
so maybe what do you do maybe that helps to calm you down or give you some kind of pleasure in your life?
Well, I mean, I used to volunteer, but I can't really do that anymore because I can't leave my home. I have a lot of anxiety. I've got agoraphobia. Sometimes I'll just be like stuck there for days.
Okay.
I feel suicidal a lot.
Okay. Wow. Do you feel suicidal today?
Well, yeah, like I feel it almost all the time. So I have like a lot of trauma and stuff. So
have you met Lydia? Yeah, she's one of our behavioral health.
Oh no, I've got a counselor and I've had a psychiatrist. So they prescribed me lorazepam and Klonopin, and so I sat there. So I don't need to see I don't need to talk to another person about it. That seems to be like kind of ridiculous. So
yeah, I know. I hear that you've got some other supports there, but here at our clinic, we really work as a team to try to understand how all different parts of our experience affect our pain. So why don't you just sit tight for a sec? I'm just gonna pop out and get Lydia. She's gonna be super helpful to us here. So just sit tight. Oh, hey, hi, Chloe. Okay, just sit tight there.
Round of applause for Dr. Solitara, the actress. So I just have to tell you guys really quickly that a friend of mine came to help us make that video, and Rachel and I were kind of cracking up the whole time, and my friend just wasn't finding it funny, and finally she was like, "So these are like primary care jokes?" And I was like, "Oh yeah, yes, these are primary care jokes, yes." I didn't realize that everyone else wouldn't find them funny, but I'm glad that you all in this room understood them. So, yep. Yeah, and just to clarify, the intent of that video, of course, is not to sort of poke fun at patients with a history of trauma. Rather, I think that video is such a perfect example of how we try to be patient-centered, and we end up having wobbly and loose boundaries, and then also don't really know how to help patients. We don't actually have the resources to help patients. So that's that primary care joke piece that I was talking to my friend about. That's what we're poking fun at, not the patients themselves. So now what I want to do on that note is I want to flip this around and talk about, okay, Lainey, what was Lainey's experience like? We just talked about what our experience was like in that room. We have a lot of frustration, a lot of burdens that we carry around. So what does Lainey actually experience in that room when we're having those difficult conversations? So Laura Heatseeker, that I mentioned earlier, the clinical social worker down in Southern Oregon, Jackson Care Connect actually asked patients what their experience was like during these difficult conversations. And so patients had a lot of things to say that I think in some ways are intuitive, and yet we're so busy thinking and feeling our burdens that we forget sometimes to turn this around and think about what the patient is experiencing. So the patient says that they were made to feel like they did something wrong. And I can't tell you how many times I think back on patient encounters I have and think that I probably did something that made a patient feel that they'd done something wrong. And I talk specifically about this in the context of benzos, but I think we can relate it to opiates as well. It used to be that in psychiatry, people had anxiety, we gave them benzos. We kind of gave them out like candy. Now we know that it's unsafe. We know that it's not usually beneficial. We know that in diagnoses like trauma, it actually exacerbates the symptoms and makes things worse over time. And so we're coming into the room and now kind of interacting with the patient who's asking us for benzos that make them feel better as though they've done something wrong. But it's actually my profession, our profession, that didn't understand the complexity or the dangerousness of these medications. And yet patients carry this burden and feel like we're saying, you've done something wrong or there's something wrong with you. They were made to feel like a criminal or a drug addict. And I don't want to put this one up and say that we're never looking at addiction, because I think often we are looking at addiction. And yet patients' experience that they're a criminal or they're an addict is similar to this experience that they've done something wrong. Oftentimes these patients, if they're addicted, it's iatrogenic, right? Oftentimes we've created this. And so then we come into this room and we have this conversation where all of a sudden in our eyes they're an addict or they're a criminal, But we're actually the ones responsible. Well, if I could step over here just for a second and be a little bit political, I would say it's Big Pharma that's responsible. They're the ones that really lied and said, hey, these drugs are totally safe. They don't cause addiction. It's totally fine. Use them as much as you want. Now, 20 years later, we have this thing called the opiate epidemic. People are dying, people are addicted, etc. But patients experience it from us that they're the criminal or they're the drug addict. They felt like they were being punished. So they felt like maybe they had a dirty UA or they felt like there was some kind of discrepancy, and so the punishment was to take away the medications, which is different than how we may view it, which is we think we're providing good medicine and we think that we're doing things that are safe. You had a dirty UA, okay, we need to decrease your opiates. You're not safe right now. And yet the way patients experience that is punishment for their behavior or They felt like they were being talked down to. So patients felt like they weren't sort of being met by the provider. They felt like they weren't in collaboration with the provider. They felt like the provider was making just these decisions about their life, pretty intense decisions, and they didn't feel like they were being included, and they felt like they were being condescended to, essentially. And again, this brings us back to this kind of hard dichotomy sometimes between being patient-centered and also really focusing on safety and protecting ourselves. They didn't understand why they were being forced to make these changes. So patients often felt like they didn't understand. A provider came in, all of a sudden we need to start decreasing your opiates, and yet no one really had a conversation about why that would be. Maybe no one spent time talking to them about safety. No one spent time saying, I'm concerned about your well-being. I'm concerned about your pain. And so that's why we're going to make this change. The other thing, and I know I'm guilty of this, I'm sure several of us are guilty of this in the room, is patients said that they felt like the provider didn't have concern for their pain, only the policy. So I imagine that the way that this translated for providers is that it's much easier to say there's a new policy in the clinic that I have to have your milliequivalents at XYZ dose. And so today we need to start decreasing. That's an easier conversation. It's shorter, it takes less time, it's less burdensome on you, it's less emotional for you than to say, I really want to talk to you about safety and to really meet that person where they're at. And so what patients experienced was that providers only cared about the clinic policy. They didn't care about their pain, they didn't care about their functionality, etc. So now knowing that those are some of your complaints, we've talked about how you guys experience, and then also knowing what the patients experience, let's talk about some skills so that we can boost that experience for everyone involved. So we know, and again this goes back to patient-centered care, although it's tricky, we know that patients feel better and we feel better. We feel like better providers when we're actively engaging people in their care. So rather than saying the policy says